Hi, everyone. My name is Linda, and I'm one of the directors of the Genomics Laboratory at Mayo Clinic, where carrier screening actually comprises the bulk of our germline genetic testing volumes. So I'm here today to provide a brief high-level overview of expanded carrier screening, or ECS for short. I'll be discussing what it is, why one might want to offer it, what it should include, and the Mayo experience with it thus far. I'll then end with some interesting cases that we've encountered that highlight some of the challenges and unexpected findings that can occur with ECS. So just a brief disclaimer, I am not endorsing any particular product with this presentation, and Thermo provided no remuneration to me for this presentation as well. So what is expanded carrier screening? Well, universal or pan-ethnic or expanded carrier screening, again, ECS for short, panels are tests which include typically 20 or more inherited, mostly autosomal recessive disorders. The target population for this test is couples who are pregnant or are planning to be. And so in the US alone, this is actually over 6 million individuals. And for individuals of certain ancestries, such as Ashkenazi Jewish individuals, both the American College of Obstetrics and Gynecology and the American College of Medical Genetics and Genomics have actually recommended genetic testing for multiple disorders for quite some time now, at least a couple of decades. And since then, numerous professional societies and articles in the literature have actually acknowledged, though, the benefits of ECS. And so ECS is actually becoming an increasingly common practice. So why offer it? Well, for starters, new technologies have actually made it really convenient and economical now to screen for a large number of different disorders that affect different individuals of many different ancestries. And so that's one thing. Another reason to consider offering ECS is that patients may actually be unsure of their ancestry, for instance, if they're adopted, or they may be of mixed ancestry. And as we know, with human migration over time, the quote-unquote general population in any given country is becoming more and more diverse. By offering an expanded carrier screen as opposed to a more limited panel that includes only one or a few genes, you actually will have, of course, a higher detection rate for disorders, and therefore, if you get a negative test result, that means a lower residual risk for that individual or couple for many different conditions. And so it's no surprise then that the experience of our own OBGYN as well as maternal fetal medicine providers here at Mayo has been in recent years characterized by a growing interest in ECS rather than smaller panels or single gene testing. So here's a direct quote actually from one of my colleagues, for instance, Dr. Myra Wick. She is both an OBGYN and a medical geneticist and a former genetics laboratory director. So if there's anybody who can comment with some expertise on this topic, it would definitely be her. And what she stated was, I am definitely ordering a much higher volume of expanded carrier screening compared to the volume of cystic fibrosis screening, or CF for short. In the past, patients were not that interested in CF screening. Patients seem to be much more interested in the ECS. And so what should an ECS include? Well, as per the American College of Medical Genetics and Genomics, or ACMG, the disorders that are being tested for should be of a nature that most at-risk patients and their partners would consider having a prenatal diagnosis, if positive, to facilitate reproductive decisions. Now, there's still quite a bit of controversy and or debate over whether one should include disorders with variable expressivity or incomplete penetrance, as well as adult onset disorders. So a classic example of this would be iron overload and severe liver disease due to hereditary hemochromatosis, for instance. Only about 40% of homozygotes for the most common mutation in individuals of Northern European Caucasian ancestry actually go on to develop serious iron overload in this disorder. And so, as one can imagine, it can be really tricky to counsel expectant parents on diseases such as this. And so, for these types of conditions, ACMG actually doesn't state whether one should or should not include them, but rather they simply recommend that labs make them optional, for instance, and be fully transparent about which disorders on your testing panel are of this nature. In addition to that, they recommend that extra consent be required for adult onset disorders. Now, I acknowledge that this is somewhat of a slippery slope here, and that professional societies, such as the American Academy of Pediatrics, for instance, typically recommend against pre-symptomatic testing of children, for instance, for adult onset diseases like Huntington's, for instance, or cancer predisposition syndromes, as that's thought to violate their future autonomy. But then on the other hand, carrier screening for and even prenatal diagnosis of such conditions could be performed during pregnancy. So at this time, actually here at Mayo, our policy is to steer clear of these issues and just simply not perform expanded carrier screening for these at all. So moving on, it's the additional recommendation that the mutations being tested for by your ECS panel have a clinically validated disease association. In other words, variants that are, for instance, variants of uncertain significance, or VUSs for short, may not be optimal simply because disease causality hasn't been established for these. And in fact, many of these VUSs will actually go on to be later reclassified as likely benign. And so one wouldn't necessarily want a couple making decisions regarding their pregnancies based on such uncertainty, right? On the other hand, one may want to consider including disorders, which may or may not be severe actually, that are treatable, especially those where early diagnosis is going to make a difference, or the condition, say, isn't one that's detected by newborn screening. And so one example of this is biotin thiamine responsive basal ganglia disease. So here at Mayo, we've actually seen a number of patients with this otherwise really rare disorder, and almost exclusively in individuals from the Middle East. And this is a disorder where early and lifelong treatment, emphasis on the early part, with just the vitamins biotin and thiamine will actually significantly impact the clinical outcomes in affected individuals. And so this is a condition where, again, you might want to consider it because that early intervention is going to make all the difference in the world for that patient. And so here in the US, unfortunately, we don't currently offer newborn screening for this disorder, but again, it could be one that you consider for ECS because it can't be picked up by, here in the US at least, our newborn screening assays in each state. Okay, so on to what to report. I'd like to briefly touch upon some points to consider in terms of reporting. It's pretty much mandatory, for instance, or at least it's of the utmost clinical utility from the provider and the patient's perspective, that one include the residual risk on your report. Namely, what is the risk that a patient could still be a carrier for the disorders being tested for, even if they get a negative result? And so in order to determine this, you actually have to perform Bayesian analysis, as we call it. And I won't go into the details of those calculations just in the interest of time. But this is a way to estimate the patient's new or modified post-test probability of still being a carrier for any disorder on your panel, even if they have a negative test result. And so this calculation requires knowledge of at least two things, and that is the carrier frequency within the population, or specifically, or even better, within the ancestry, of your patients, or that the subpopulation that they are a member of, as well as the proportion of disease-causing alleles detected by your test. I'd like to point out, however, that populations can be quite tricky to define. A great example of this is using the World Health Organization's regions, or their published regional carrier frequencies, for hemoglobinopathies, such as sickle cell disease, for instance, or alpha-thalassemia. And so the WHO actually divided up the world into these regions shown here when making their carrier frequency determinations. The problem is, looking at these, and without reading their published article on these, they're not really all intuitive in many cases. So for instance, Thailand is listed under Southeast Asia, which they have a hyphen in between South and East. But then the neighboring countries of Vietnam, Cambodia, and Laos are actually lumped together with Western Pacific. China is included in Southeast Asian, but then neighboring Mongolia is actually included in Western Pacific, even though they're neighbors and Mongolia is landlocked. Korea is inexplicably included in both Southeast Asia and Western Pacific, and they didn't really state why. I'm not sure if they divided up North and South, for instance. But at any rate, hopefully you get the idea that it's not necessarily intuitive looking at these regions what you might actually belong to. Therefore, what is your actual carrier frequency and or risk calculated based on that if you were to be tested for these hemoglobinopathies. Now, as I touched upon earlier, it's still quite debatable whether one should be reporting VUSs if your testing method involves full gene sequencing as opposed to a targeted genotyping for specific alleles. I previously posed the question that one wouldn't necessarily want a couple making pregnancy decisions based on a VUS that in all likelihood may go on to be classified as likely benign on the previous slide. But what if the opposite scenario were actually to occur? I actually saw a recent post on the Genetic Support Foundation's blog from a genetic counselor where this exact situation happened. And I'm so grateful that he posted about this because it really opened my eyes. He had a patient with first trimester expanded carrier screening that was all negative at that time. But then as this patient was nearing her due date and in the final weeks of her pregnancy, the lab actually sent him an amended report stating that there was a VUS that they had previously detected in this patient that they didn't initially report, but now they were updating the classification of this VUS to likely pathogenic, and now they were reporting it. So boom, instantly, this patient at the beginning of her pregnancy went from having a completely negative ECS to now she's positive and a carrier for a severe childhood onset disorder. And so what a conundrum, right? It led to, not surprisingly, so many thoughtful questions that the scenario that arose. For instance, do other labs track VUSs besides this one lab that this GC had experience with? Should they even be tracking VUSs? How often do they reanalyze those VUSs and potentially upgrade their classifications of these? And should there be a set timeline for that? At the end of the day, the main take-home point for me from this really enlightening blog post was that perhaps labs at a minimum need to be transparent in their test information that they're going to be tracking these VUSs and potentially updating patient results based on those. So moving on to the next issue, one of the things that our providers here at Mayo have actually commented that they really like from certain labs, since they've actually tried out multiple different labs for ECS, is combined reports. Namely, a single report that includes both partners' results and their residual risk as a couple on one convenient single document. Extremely helpful because, again, all of your information is right there in the single document, and all the calculations for that couple, as opposed to the individual partners, have been performed for you and, again, are easily accessible and right in front of you when you're having that appointment with that patient to counsel them on the results. Problem is, from a lab perspective, this poses a bit of a dilemma. As we know, couples may not be together forever. And so, actually, in fact, many will go on to uncouple and perhaps have children in the future with different partners. And so by issuing a combined report, are we potentially violating HIPAA and revealing protected health information about a previous partner to a new partner who isn't actually entitled to such information? So just some food for thought. Okay, so I'd now like to switch gears and talk about the experience of Mayo ordering providers during their first year of putting ECS into practice, and then highlight a few interesting cases that we've encountered with carrier screening on the laboratory side. So in the first year of implementing ECS, OB-GYN actually had, unexpected to them and actually to us as a lab too, a higher hit rate, for lack of a better term, than they thought that they would encounter. So out of 106 patients that first year who decided to go ahead with ECS, nearly 30% of them were actually positive or were positive carriers for a variety of different disorders. And so I've listed a sampling of some of those conditions here on this slide. And then of those, at least 11 or about 10% of these individuals were carriers for more than one condition. And so here on this slide, I have groupings of disorders for which one individual was a carrier of. So the first one, this individual was positive or had positive carrier status for all three of these conditions. And unexpectedly, one patient actually turned out to be affected with one of the disorders being tested for. And so this patient actually carried two mutations is the ALDO-B gene, which is known to cause hereditary fructose intolerance. And this disorder can actually be really severe and even lead to death in children. And so she never knew that she actually had this disorder, but as it turns out, she had actually avoided sources of fructose ever since she was a child, because it was noted that ever since childhood that ingesting these made her really ill. On that note, then I'd like to move on to some interesting laboratory cases that we've had, starting with cystic fibrosis, or CF. And so cystic fibrosis is, of course, the most common, potentially lethal autosomal recessive disorder in the Northern European Caucasian population. It's caused by mutations in a gene known as CFTR. And both ACOG and ACMG recommend carrier screening to all women who are planning to become or are currently pregnant for CF, regardless of their ethnicity. And I've included a table here just showing some of the carrier frequencies for CF amongst individuals of different ancestry. So as you can see, in the European Caucasian population, for instance, the carrier frequency is 1 in 25. So it's not that uncommon. And so we actually perform upwards of 20,000 carrier screening tests for CF alone here at Mayo. It's one of our highest volume assays on the germline testing side. And interestingly, in the past year alone, we actually identified at least 3 patients who were affected, not just carriers of, but affected with atypical CF. And of these, one was actually a male patient who had congenital bilateral absence of the vas deferens, or CBAVD for short. So he was infertile, and unfortunately, as it turns out, he was not the father then of his partner's current pregnancy. So again, just something to bear in mind when offering ECS. You're likely to uncover affected individuals over time, especially for milder disorders or milder forms of certain disorders. And of course, patients will hopefully be counseled on this possibility, and labs will hopefully disclose this possibility in their test information. Likewise, you may uncover non-paternity as well. So remember that an estimated, and this is just an estimate, of course the number is quite controversial, but an estimated 3% of pregnancies in at least the Northern European Caucasian population have misattributed paternity. So again, just food for thought and something to bear in mind when offering this sort of testing. Our second set of interesting cases involves alpha-thalassemia. And so alpha-thalassemia is actually the most common autosomal recessive condition worldwide, not just in the Northern European Caucasian population. There are actually nearly 300 million carriers and at least 300,000 severely affected infants that are born each year with alpha-thalassemia, with over 95% of cases occurring in Southeast Asia and the Middle East. And alpha-thalassemia involves the HbA1 and HbA2 genes, and these produce the alpha chains in hemoglobin. And hemoglobin, of course, is what's responsible for carrying oxygen in our red blood cells. And so Mayo actually offers a standalone assay for alpha-thalassemia where we're just looking for copy number variants using multiplex ligation probe amplification. And this standalone assay both unfortunately and fortunately includes a control probe for copy number on the X chromosome. And so what we found over the years, and we perform upwards of 4,000 of these each year, is that we have about 5 cases annually where we uncover incidentally sex chromosome abnormalities in patients because of that control probe that we include on the X chromosome. So these are cytogenetically confirmed cases of mostly Turner syndrome and Klinefelter syndrome. So 45X females for Turner syndrome or 47XXY males for Klinefelter syndrome. We even had a mosaic Turner syndrome case that had conceived naturally. And so this was uncovered, just by her carrier screening for alpha-thal. And so again, these types of incidental findings have ramifications for the parents and not just the pregnancy, and are something to bear in mind when offering ECS. And so our last interesting case involves Gaucher disease. Gaucher disease is an autosomal recessive lysosomal storage disorder caused by mutations in the GBA gene. It has a carrier frequency of 1 to 7 to 1 to 18 in the Ashkenazi Jewish population. And it's important to note that with this disorder, there's actually enzyme replacement as well as substrate reduction therapy available. And so our case was a 34-year-old asymptomatic pregnant female who was 15 weeks along at the time of testing, who had a previously positive carrier screening for Gaucher by another lab. And according to this outside test report, the patient wasn't just a carrier of, she was actually affected with Gaucher disease. And two mutations were detected by her testing, D448H as well as L483P. And I've included the historical nomenclature for these two mutations in the parentheses. That's sometimes more recognizable in the literature. And so in this case, because she got a result that said she was affected, not just a carrier, they sent full gene sequencing to our lab, as well as her husband and the patient's mother to help set phase. In other words, to determine whether those two mutations were actually in cis or on the same chromosome, meaning that she was actually a carrier and not affected, or whether they were in trans on opposite chromosomes, meaning she was indeed affected. They also sent biochemical testing for the enzyme known to be deficient in this disorder to our Mayo biochemical genetics lab, and this was performed on peripheral white blood cells. And that result was actually somewhat inconclusive. She had a slightly reduced activity that was said to be indicative of either carrier status or could be affected, but they couldn't determine which just based on that number. And so our full gene sequencing assay actually ended up being completely negative for this patient. We didn't find a single mutation, let alone the two mutations that this outside lab had detected. And of course, this got us panicking a bit because we didn't expect that to happen. And so the first thing that came to mind was there a possible sample mix-up? And so we took a couple of weeks, did our due diligence, and were able to completely rule out a sample mix-up in this case. So what is going on here? We were understandably sweating bullets at this point because the patient's provider had reached out to us over our initial negative report and was actually threatening litigation over whichever lab got the result wrong, which we completely get that because there's obviously a lot of stress and anxiety and frustration there, given that they're nearly 20 weeks along in their pregnancy at this point. And as if pregnancy itself wasn't stressful enough, now there's this possibility that mom went from news of being affected with Gaucher disease to now she's not affected at all. And so what's a lab to do in this case? Well, as it turns out, GBA actually has a pseudogene that's only 16 kilobases downstream of it. And this pseudogene has up to 98% homology with the true gene. And because of that high homology, non-reciprocal recombination events are really frequent between the two entities. And these lead to complex gene-pseudogene rearrangements and gene conversions. And so there actually have been over 20 recombinant alleles for GBA described to date, the most common of which is actually this REC-NCIL allele. And this rearrangement actually introduces 3 different mutations from the pseudogene into the functional GBA gene. And so if you're homozygous for this recombinant allele, you actually have a very severe phenotype. For example, hydrops totalis in that fetus, not compatible with life generally. And so our single gene sequencing assay for GBA actually has 2 components to it. There is a long-range PCR that we perform in order to make sure that we're isolating and interrogating true gene rather than pseudogene, then followed by the Sanger sequencing. And so our assay actually will not amplify pseudogene or recombinant alleles. And so looking back at the patient's sequencing data, we actually noticed that she was homozygous for all benign single nucleotide polymorphisms across the gene, which is unusual. Unless a patient has parents that are consanguineous, for instance, you don't typically see them being homozygous for all SNPs across an entire gene. And when we looked back at the gel electrophoresis result for her long-range PCR product, it appeared that she actually had half the normal amount of product compared to her mom, as well as normal controls. So that was a clue. And also, as it turns out, our lab has 2 assays for Gaucher disease. One is an older one that we haven't quite retired yet. And this older assay is actually a targeted bead-based SNP test for Gaucher just for specific mutations. When we ran our patient sample by that targeted method, she was actually positive for the same 2 mutations that her outside lab or her previous lab had stated that she was positive for. Her mom, however, was negative for these. Now, this targeted bead-based assay, of course, because it doesn't involve a long-range PCR amplification, is not going to be able to distinguish between true gene and pseudogene. So in sum, our conclusion from all of this is that our sequencing result likely is the product of allele dropout due to the presence of one of those rare recombinant alleles that I mentioned. And so this means that that original outside test result was actually inaccurate. And the patient is, in fact, a heterozygous carrier of and not affected with Gaucher disease. And so pseudogene interference as well as complex gene pseudogene rearrangements are also important to consider in your ECS design because it definitely occurs and it's a known issue or challenge, when designing these tests. So in summary, ECS is becoming an increasingly routine practice, and it allows for the detection of many different disorders with compelling carrier frequencies across multiple different ethnic groups. Most of these conditions are going to be severe and autosomal recessive in inheritance. Residual risk is something that's very important to report, but can be challenging to calculate. And there is, of course, controversy over whether to include VUSs as well as whether or not to issue combined reports. Unexpected and or incidental findings are not uncommon, and so it's important to take those into account, and it's also important to understand the limitations of the technology being used for your ECS. Thank you, and that is all for me.
Thank you so much, Dr. Hasadshri. That was an excellent presentation. I just have a couple of questions, and I think you did a beautiful job of explaining some of the controversies in the VUS space, but can you elaborate a little bit more about that and what most labs are doing? You gave a very nice example of a pregnant patient who had a VUS at the time of becoming pregnant and then later turned out to be have its characterization changed. So if you could talk a little bit more about some of the controversies and what most labs are doing these days in this area.
It's a great question, Amy. Without knowing what methodologies other labs are using, I can't really comment to what their specific practices are. I just know from the Mayo provider experience with a few of those labs that they are not including VUSs on their reports. But that being said, they could still be detecting them if they're using a full gene sequencing method. So we haven't had a case yet here at Mayo where a VUS ended up being reclassified or upgraded to likely pathogenic and then reported. So although, of course, as we know from the example that I gave, it is definitely a possibility, hence the controversy, because one can imagine how harrowing it is for a patient to go from a negative to suddenly a positive result, at the end of their pregnancy or even maybe after their pregnancy, which could then impact future pregnancies, right? At the same time, if there are labs out there that are reporting VUSs, we know from experience that the majority of these VUSs are actually going to be reclassified as likely benign as we get better population data and more whole genome sequences, for instance, uploaded to the population databases. What would happen if again a couple were to make a pregnancy decision based on a VUS and that ended up being reclassified as likely benign? I mean, I can't even imagine what it would be like to go through that. And so I think that's the main source of the controversy there, is that, again, with VUSs, there's no disease causality proven to occur with that variant. And so therefore, what clinical utility is it to have that on a report?
What is Mayo doing in your reporting in these cases with VUS?
So the policy of Mayo right now, for carrier screening is to, whenever possible, not even bother detecting VUSs. That being said, if we were to go the full gene sequencing route, we're going to see them. And so we will state quite clearly, in our test information that these will not be reported. However, if there is one that is found and it is reclassified, we will notify you. So please be aware that this is a possibility.
Thank you. Thanks for that. And in thinking about the size of the panels, so you gave a definition early on of what constitutes an expanded carrier screening panel, but how many genes, in your opinion, should be included, and what does Mayo currently offer?
It's also a great question. So there is no magic number, unfortunately, for how many or how few genes to include on your ECS. I do know that, of course, based on ACOG and ACMG guidelines, you at minimum are going to want to include cystic fibrosis, as well as spinal muscular atrophy and hemoglobinopathies, especially for individuals of certain ancestry. That being said, our own providers here have actually expressed that at minimum, what they would like to see on an ECS is CF, SMA or spinal muscular atrophy again, Fragile X syndrome, hemoglobinopathies, as well as the classic quote unquote classic Ashkenazi Jewish conditions, so things like Gaucher disease, Tay-Sachs, Canavan disease, etc. And that to them is what constitutes, a bare minimum. But again, that's going to vary from institution to institution and obviously patient population to patient population.
Right.
So right now, what Mayo is currently offering, sorry, to answer the second part of your question, is for our extended carrier screening, we are actually testing over 200 genes that our team actually vetted to make sure that they had compelling carrier frequencies or again, were of a nature that we felt were compliant with those ACMG and ACOG recommendations.
No, it makes sense. And I keep asking you two-part questions, but I think we have time for maybe one more, which I would also consider a two-part question. You talked about the complexity in calculating residual risk. It seems it's more common to calculate that in the Caucasian population. So I'm wondering why that is. And then how do you go about calculating residual risk for a rare variant in a non-Caucasian individual?
Another great two-part question.
Sorry.
I think that
break it up.
That's okay. That's okay. I think that the reason why residual risk calculation is more common for the Caucasian population is simply because that's the most well-studied one. So that's the one that's been published about the most and has the most, genome sequences, for instance, or exome sequences uploaded to the population databases. And so because it's been so well characterized, we just happen to know those numbers. So in order to calculate residual risk then for a rare variant in a non-Caucasian individual, or say an individual of mixed ancestry, doing is, especially if you can't really pinpoint the ancestry of that person, or it's not a neat category on a table in a publication, is you will just apply the general population risk that's known for that disorder in your Bayesian analysis for that. So again, that Bayesian analysis that needs to be performed in order to estimate an individual or a couple's residual risk of having or of being a carrier for a particular disorder if they have a negative test result by your extended reading, is going to necessitate or require, knowledge of the carrier frequency, again, in the general population in this case, if they're non-Caucasian and or of mixed ancestry, and it's not clear, it's not good that they fall neatly into a published category on a table, as well as, again, the detection rate of your test. And so if you're using like a targeted method, for instance, for your carrier screening as opposed to full gene sequencing, you should know roughly the carrier frequencies of those individual mutations in various individuals and what proportion of disease cases those make up. And then you will use those numbers to then arrive at a final, as they call it, posterior probability or modified post-test risk for that couple or that individual. Hopefully that made sense.
It actually did. It was very clear. Thank you so much, Dr. Hassadri. A very, very thoughtful presentation. Thank you again for your time.
Thank you.